Now that you have learned about the different clinical appearances of retinal macroaneurysms and the natural history, we will go on to the treatment of these lesions and also the differential diagnosis. So, what about treatment? Again, we do not have any good randomized prospective clinical trials on this entity. There's one paper that's published in 2013 of 37 patients. Half of them had hemorrhagic complications. All of them received 3 injections. Now, you have to remember, the natural history is pretty good even with no treatment. And they said the visual improvement was equivalent whether it was hemorrhagic or exudative. The problem is there's no long-term follow-up. So you don't know whether the treatment is going to shut down the macroaneurysm for 6 months or a year, or is this going to continue to progress down the road? That was not published. This paper is also published about the same time in the American Journal of Ophthalmology on 23 patients, and as usual, most of these were hemorrhagic. And if you look at the conclusion, they stated that there was no significant rapid improvement in the best corrected visual acuity in the bevacizumab treated group. And again, you would expect this because the hemorrhagic is going to get better by itself. And if you look at the graph of the best corrected visual acuity, you can see that the end result was on the final visit was about the same whether they were treated or not. Now just a word about pneumatic displacement of subretinal hemorrhaging. First, if it is sub-RPE, pneumatic displacement does not work. You don't get sub-RPE hemorrhaging from macroaneurysms, but you do from vascular macular degeneration. And this is one thing you do want to separate out, whether it's the vascular degeneration or a macroaneurysm. If it is subretinal, and if you do pneumatic displacement, the procedure first, the indications are that the hemorrhage has to be present for less than 7 days. It should be relatively thick. The pneumatic displacement does not do anything for thin subretinal hemorrhages. One does a pars plana vitrectomy, and you have to inject TPA under the retina. Hillel Lewis has done work showing that injection of TPA into the vitreous does not get into the subretinal space. So you want to do the vitrectomy, inject the TPA under the retina, and then do a partial air fluid exchange so you can steamroller the blood out of the area and of the macular area. Laser has been done on many patients with macroaneurysms, and it can be quite beneficial. But again, there are no prospective clinical trials on this. The advantages is it does work. You can stop the exudation, and you can preserve the vision. The complications would be either bursting the macroaneurysm or occluding the peripheral arteriole. If you're going to laser, you want a spot size that is very large, either 500 to 1,000 microns in spot size. You want a low energy, and you want the time to be either half a second or a full second. A small, high-powered will burst the aneurysm, so you want a low and slow laser burn. Here's a patient who came in with a 1-month history of blurred vision. She had a history of hypertension, and the systolic was elevated at 158, and the diastolic was fairly good at 88. Her vision was 3/200 when she came in. Because she had a hemorrhage, we did elect to follow because we figured this probably will shut down on its own. There is sign of chronic exudation. You can see this by the hard exudates just temporal to the fovea. The fluorescein angiogram does demonstrate the 2 aneurysms on the same arteriole quite well. Well, because the patient did have a hemorrhage, and the natural histories, usually these things do shut down on their own, we watched closely. 2 months later, the vision dropped to about 20/80. You can see more exudation, and the blood is dehemoglobinizing out temporally. The aneurysms look a little bit larger, and they're still open and they're very red. Because of this, we did elect to go ahead and give focal photocoagulation to both of the aneurysms. So, 2 months later, the vision is getting better at 20/60. The hard exudates are present, but getting better. The hemorrhage temporally is continuing to absorb. The double arrow points to the occluded macroaneurysms. The vessel just beyond it is a little bit white, so we may have shut down the blood flow a little bit. And the single arrow points to an atheroma just nasal and just proximal to the occluded macroaneurysms. So here's the same patient. 6 months later, the vision is back to 20/40. You can see the atheroma proximally and the two fibrotic macroaneurysms. The heart exudates are still there, and the subretinal hemorrhaging is almost all gone. A year later, the fovea looks good, the exudates are gone, the little atheromatous plaque is also starting to absorb, and you can see very well the two fibrotic macroaneurysms a little distal. So here's our last example. This patient came in with some blurred vision. You can see a very large macroaneurysm along the infratemporal arteriole. This is accompanied by subretinal fluid and exudates. Again, because there are no prospective clinical trials showing the benefit of laser, again, we decided to watch this patient closely and see what would happen. So, again, we elected to observe this patient, and you can see that 3 months later, he had a tremendous amount of exudation and a very large and dense circinate pattern. The fluorescein angiogram showed the macroaneurysm quite well. And here's the patient 1 year later. The aneurysm is quite fibrotic, but there's still a lot of exudates. And again, exudates take a number of months to develop, and once they're there, they can go away, but it can take a long time. 18 months later, the aneurysm still is fibrotic. It is not reopened, and the exudates are much better, and his vision is getting better, but it is still blurred at about the 20/60 level. So what's the differential for macular hemorrhaging, exudates, and vascular problems? Well, the obvious: diabetic retinopathy, and then retinal telangiectasia, retinal capillary hemangiomas, cavernous hemangiomas, hemorrhagic pigment epithelial detachments, and vascular macular degeneration. So I'm going to now show some comparisons between some of these entities and macroaneurysms. So the patient on the left, on the top and the bottom, have macroaneurysms. The one on the top was a little bit later, and it shows some abnormal vascularity and some hemorrhaging. On the bottom were the two macroaneurysms, the atheromatous plaque, heart exudates, and old resolving subretinal hemorrhage. The patient on the right has Coats disease. Again, there's a large aneurysm along the infratemporal arteriole, but the difference is the entire arteriole is sclerotic and white. And if you look at the fluorescein angiogram, there's capillary loss and some pretty prominent telangiectatic vessels. These two findings on the angiogram are not compatible with the diagnosis of a macroaneurysm. So that is one way to distinguish between a macroaneurysm and retinal telangiectasia or Coats disease. Here is an example of a macroaneurysm on the left and a retinal capillary hemangioma on the right. The macroaneurysm is large. It is both red and white. There's exudation and maybe a little bit of hemorrhaging. The retinal capillary hemangioma on the right is large, obviously, reddish white, subretinal hemorrhaging, and exudates. But you can see that a capillary hemangioma is going to have a large feeder vessel, and it's going to have a large draining vessel. Macroaneurysms do not have feeder vessels, and the venous system around it is normal. I'm using the same example of the macroaneurysm on the left in that there's multiple aneurysms on the same arteriole. The cavernous hemangioma on the right also has numerous aneurysms, but you can see that these are saccular and it is a totally different appearance than on the macroaneurysm because there are multiple cavernous cavities uh, and not just a single one. So here's a comparison of a macroaneurysm and hemorrhagic exudative macular degeneration. Again, the aneurysm's on the left. On the upper right is a lady who was referred in for a change in her choroidal nevus, which you can see at 3 o'clock. The nevus is present, as you can see, and overlying it are some old hard exudates. However, if you look at 12 o'clock, she has an extra macular choroidal nevascular membrane with hemorrhaging and dependent hard exudates. Several years after we photographed her left eye, she came down with a hemorrhagic exudative macular degeneration on the right. And this hemorrhage is actually sub-RPE. It is not sub-retinal. It looks very similar. It's round, well described, purplish in color. It is overlying a arteriole. However, just using the clinical experience and the diagnosis of having had really bad RPE in the choroidal nevascular membrane on the left side, we neglected to watch, and this indeed was the macular degeneration and not a macroaneurysm.